Okay, so this gets us to the next question, that is question number 144. Question 144. Now, what the examiner is asking you is 48 man severe substernal chest pain radiated to left arm, 4 years later increasing dyspnea, orthopnea. So basically it is a case of MI decreased cardiac output with ejection fraction of 29%. All this is showing this as MI. Most likely to be indicative of the original acute event is troponin I release from the myofibers. I guess no explanation is needed in this case. Scar tissue is the later phase. Passive congestion liver, no. Organizing mural thrombus, no. So the only answer that is left is answer A, that is troponin I release. Troponin I release from myofibers. Troponin I release from the myofibers. From myofibers. This is the only answer. There was, I guess, absolutely no confusion in this. This is question 144. Next, this gets us to the next question, that is question 145. Question 145. Down syndrome causes mental retardation. Fair enough, it is the most common cause of mental retardation, most common genetic cause of mental retardation, Downs. Which of the following is not associated with Downs? Downs is trisomy 21. Fair enough. Mosaic 21. Agreed. Some cells may have trisomy 21, some may not. Mosaic 21. Agreed. Robertsonian translocation 2121 or 1421. Fair enough. Deletion 21, that is absolutely not there. See, the minute you see this, A and B are 100% true, there is no doubt about it. C, you can be dicey whether you know it or not, but D is absolutely wrong. So question number 145, deletion of chromosome 21. Deletion of chromosome 21 is not a feature. It is not a feature. And the most common cause, so firstly, the most common genetic cause, let us add 2 points here. Most common genetic cause of mental retardation. Most common genetic cause of mental retardation is Down syndrome. This is asked, it is Down syndrome, followed by, that is the second most common genetic cause of mental retardation, followed by Fragile X syndrome. Followed by Fragile X syndrome. Next point, another term that was used in one of the options was Robertsonian translocation. Let us have a look at that also. Translocations, they are of two types: reciprocal translocation and Robertsonian translocation. Reciprocal and Robertsonian translocation. So translocations, they are of two types: reciprocal and Robertsonian. Reciprocal translocation means one part of the DNA has gone to the other and vice versa. That is reciprocal. In this, there is no loss. In this, there is no loss of genetic material. There is no loss of genetic material. Versus Robertsonian translocation, which first point occurs in acrocentric chromosomes. Acrocentric chromosomes. Acrocentric chromosome, this is a chromosome in which centromere is present on one side. So you have a very short arm and a very long arm. Acrocentric chromosomes, and this is associated with loss of genetic material. This is associated with loss of genetic material. So what do we mean by this? There is a very short arm and a very long arm. So when translocation occurs, it leads to the formation of a very large chromosome and a very small chromosome. A very small chromosome. This small chromosomal genetic material is lost. This is Robertsonian translocation. Robertsonian translocation. Next point. In Downs, it can be associated with Robertsonian translocation between 14 and 21. Next, this gets us to the next question, that is question number 146. This gets us to 146. All of the following are true with Hashimoto's. Hashimoto's thyroiditis, this is the most common cause of hypothyroidism in iodine sufficient areas. You know that. All are true except follicular destruction. Agreed. Increase in lymphocytes, oncocytic metaplasia. All these are the features. Even if you do not know oncocytic metaplasia, let's put a question mark on that. But you are very surely aware that orphan ani nucleus is the diagnostic hallmark of PTC, not Hashimoto's. So question 146, the answer is D, that is orphan ani nucleus. Orphan ani nucleus. This is the diagnostic hallmark. This is the diagnostic hallmark of PTC, papillary thyroid carcinoma, orphan ani nucleus. What do we see in this? Orphan ani nucleus, it is a large nucleus. It is a large nucleus with prominent nucleoli. Large nucleus with prominent nucleoli. This is what it looks like. I'll show it to you microscopically. Versus Hashimoto's thyroiditis. Versus Hashimoto's thyroiditis, which microscopically shows a dense lymphocytic infiltrate. Which microscopically shows a dense lymphocytic infiltrate with well-defined germinal centers. With well-defined germinal centers, with entrapped thyroid. With entrapped thyroid. This is Hashimoto's thyroiditis. It shows dense lymphocytic infiltrate with well-defined germinal centers with entrapped thyroid. This is Hashimoto's thyroiditis. So before we go further, let us see what it looks like microscopically. Starting with the first image, have a look at this. Have a look at this. This is the classical orphan ani nucleus. First point, how do we identify this as thyroid? We know this is thyroid by the presence of thyroid follicles with colloid in it, making this as thyroid. Showing the presence of large nuclei with prominent nucleoli. Large nuclei with prominent nucleoli. Have a look at all the cells. This is what they look like. This is the orphan ani nucleus seen in PTC. Seen in PTC, papillary thyroid carcinoma, seen in PTC. Next point. Let us see the next one, that is have a look at this one now. So we have already discussed this, but have a look at this again. What this shows you is the presence of, what is the parent organ? Thyroid. Showing you the presence of thyroid follicles with dense lymphocytic infiltrate with presence of well-defined lighter areas, which are the germinal centers, with entrapped thyroid, making this as Hashimoto's thyroiditis. Making this as Hashimoto's thyroiditis. Done. Next, this gets us to the next question, that is question 147. This gets us to the next one, that is 147. Not commonly seen in anterior mediastinum are the neural tumors? Answer is P. Question 147. Not seen in anterior mediastinum are the neural tumors. So I can divide the mediastinal lesions into those of anterior mediastinum, middle mediastinum and posterior mediastinum. Anterior, middle and posterior mediastinum. I can divide the lesions into three types. The anterior mediastinal lesions, these are all the thymomas, thymic carcinoma, Hodgkin's lymphomas, thymic carcinomas, Hodgkin's lymphomas, non-Hodgkin's lymphomas, germ cell tumors, that is, they are also associated with teratomas. It is also a germ cell tumor only, teratomas, and of course the thyroid lesions. These are all which occur in anterior mediastinum. Nothing to rectify, obvious. Thymomas, thymic carcinomas, Hodgkin's, non-Hodgkin's, germ cell, teratoma, thyroid lesions. Next are the middle mediastinal ones. Next is middle mediastinum, which is associated with esophageal tumors, parathyroid adenomas, adenomas, pericardiac cyst, and bronchogenic cyst. Pericardiac cyst and bronchogenic. They are the middle mediastinal versus posterior mediastinal, which are the neural tumors, that is the neurogenic tumors and the neuroendocrine tumors. This is how we can divide the tumors of the lesions of the mediastinum into anterior, middle and posterior mediastinum. Next, this gets us to the next question, that is question number 148. This gets us to question 148. Hyperacute graft rejection. The name tells you that is seen within minutes. Question 148. The answer is D, that is in minutes. We have discussed graft rejection and its types, various times. It is of three types: hyperacute, acute, chronic. Here I will limit myself to hyperacute graft rejection. The name tells you everything. Suppose I have taken the graft, my body is rejecting it. That is called as graft rejection. First point, why does hyperacute graft rejection occur? Because of preformed antibodies. This occurs because of the presence of preformed antibodies in the recipient. I took the graft, my body rejected it. So I had preformed antibodies against the donor in the recipient. That is hyperacute graft rejection, seen within minutes of receiving the graft. This is antibody mediated. So which type of hypersensitivity reaction? Type 2 hypersensitivity. You very well know 4 hypersensitivities. One is type 1 is allergic response, type 2 antibody mediated, type 3 antigen antibody immune complex reaction, type 4 delayed type. This is type 2 antibody mediated. Microscopically shows two lesions. The first is fibrinoid necrosis. Whenever we made the list of fibrinoid necrosis, we wrote graft rejection hyperacute phase. Fibrinoid necrosis and thrombotic occlusion of capillaries. Fibrinoid necrosis and thrombotic occlusion of capillaries. This is hyperacute graft rejection. Next, this gets us to the next question, that is question number 149. This gets us to the next one, that is question 149. Opsonization is done by C3b. The answer is B, that is C3b. Again, an important easy list repeatedly asked. The opsonization agents are, what are opsonization agents? They are the substances which makes the bacteria, which makes the bacteria tasty for phagocytosis, which makes the bacteria tasty for phagocytosis. This is not my language, this is what Robin says. So, what are the list of opsonization agents? The opsonization agents are C3b. Please note C5a is a chemotactic agent. C3b is an opsonization agent. Fc fragment of IgG. You know that antibodies has two regions, FAB, fragment antigen binding, and an Fc end. Fc fragment of IgG. Mannose, CRP, and fibrinogen. Mannose, CRP, and fibrinogen. These are the opsonization agents. Next, this gets us to the next question, that is question 150. This gets us to the next one, that is question number 150. Nude mice can accept xenograft because it lacks T cells. The answer is A, that is T cells. Nude mice, they can accept xenografts because they lack T cells. Let us see this in slight more detail. Firstly, what is a xenograft? Xenograft, it is a tissue graft. It is a tissue graft or organ transplant. It is a tissue graft or an organ transplant from a donor of different species. This is a xenograft. The examiner was asking you that nude mice can receive xenograft because, so what is nude mouse? What is a nude mouse? This is the main outward appearance. Why is it called as nude? This is the main outward appearance of the mouse. It is the main outward appearance of the mouse which lacks body hair. So it is called as nude mouse. What is its main feature? Nude mouse, it is a lab mouse from a strain. It is lab mouse from a strain with genetic mutations. That cause a absent thymus. In turn, you very well know that thymus is where the maturation of T cells take place. In turn, leading to a greatly reduced number of T cells. So, nude mice, it is called as nude because of the outward appearance. They lack hair. It is called as nude because they lack hair. Next point, the thymus is absent or reduced. As a result, there is reduced number of T cells. So they can accept xenografts. They can accept xenografts. Next, this gets us to the next question, that is question number 151. This gets us to the next one, that is question 151. 56 male presented with lesion at lung apex. What is your diagnosis? See, the minute we see this is electron microscopy showing the presence of elongated microvilli. Have a look at this. These are the elongated microvilli. So this is a case of mesothelioma. This is a case of mesothelioma. The electron microscopic appearance of adenocarcinoma versus mesothelioma. Let us have a look at it. Let us make a table of the same. Mesothelioma versus adenocarcinomas. We are of course talking of lungs here. Mesothelioma versus adenocarcinoma. Mesothelioma, it shows the presence of long and slender microvilli. This was what was given in the paper. The microvilli, they were long and slender, versus the short and plump microvilli. I'll show it to you. Versus the short and plump microvilli of adenocarcinoma. Next point, markers. Mesothelioma, it is calretinin, WT1 and cytokeratin's 5 and 6 positive. Mesothelioma, it is calretinin, WT1 and cytokeratin 5-6 positive. Versus adenocarcinomas, which are CEA, carcinoembryonic antigen, CEA and TTF1, that is thyroid transcription factor positive. This table is important. TTF1, that is thyroid transcription factor 1 positive. This is mesothelioma versus adenocarcinomas. So before we go further, let us see what it looks like on electron microscopy. Let us see what it looks like on electron microscopy. Have a look at this. Have a look at this. This is the electron microscopy of mesothelioma, which is showing the presence of long curved microvilli, versus adenocarcinoma showing short plump microvilli, So this is adenocarcinoma versus mesothelioma. Next, this gets us to the next question, that is question 152. This gets us to the next question 152. Have a look at the image. Firstly, cavitary region, right lower lung, following appearance. Nothing to be discussed in this. Have a look at the image. It is showing the presence of a paragonymous egg with 2 layers. You are able to make out the 2 layers. This is paragonymous egg with 2 layers. This has to be remembered. This is a factual question. This is what it looks like, paragonymous with 2 layers. Next, so let us just write this question 152. The answer is C, that is paragonymous egg with 2 layers, Next, this gets us to question 153. Now what you see here is pruritic erythematous dye-raised lesion over the vulva. Diagnosis. You are able to see the presence of large cells. Large cells, arrow is also put there. Large vacuolated cells. Let me show it again. The presence of large vacuolated cells with prominent nucleoli. All these are the Paget cells. So diagnosis, Paget's disease. Diagnosis, Paget's disease. Just a sec, let me enlarge it. Paget's disease. So question 153, the answer is A, that is Paget's disease. What do we see here? Microscopically, microscopically, it shows the presence of single as well as small clusters of cells, as well as small clusters of large cells. Small clusters of large cells. The cells are large in size with presence of vacuolations, large nuclei and prominent nucleoli. Large nuclei and prominent nucleoli. This was what we were seeing in the image. Large cells, large nucleus, prominent nucleoli. They are the Paget cells. So diagnosis, Paget's disease. Paget's disease. Next, this gets us to the next question, that is question 154. This gets us to the next one, that is 154. In Alzheimer's, what is incorrect? Alzheimer's, we have discussed this at least twice or thrice in the paper. Is intracellular neurofibrillary tangles. This is true. Intracellular neuritic plaques. That is also true. Next, loss of cholinergic neurons in the nucleus basal of Marinette. This is an additional information and is true. Loss of recent memory. No, it is not associated with the loss of recent memory, but with the later memory. So the answer to question 154 is D, that is loss of recent memory. Loss of recent memory. Loss of recent memory. This is Alzheimer's. This is Alzheimer's. The rest of the options associated with this were correct. Next, this gets us to the next question, that is question 155. BT, that is bleeding time, is increased in the deficiency of von Willebrand disease. See, hemophilias A and B, they are associated with increased PTTK. The bleeding time is not increased, but it is increased in the deficiency of von Willebrand disease. That is in the deficiency of von Willebrand disease. So first point, let us have a look at von Willebrand disease. Von Willebrand disease, it is of three types: type 1, type 2 and type 3. Type 1, type 2 and type 3. First point, type 1 and type 3 are quantitative defects. Type 1 and type 3 are quantitative defects, whereas type 2 is a qualitative defect. Type 2 is a qualitative defect. First point. Next, type 1 is associated with mild deficiency, whereas type 3 is with severe deficiency. They were quantitative, so type 1 is mild deficiency, type 3 is severe deficiency. Next point, type 1 and which is the most common? Type 1. Next, type 1 and type 2 are autosomal dominant in nature, whereas type 3 is autosomal recessive. So if you are asked the inheritance pattern of von Willebrand disease, autosomal dominant, because the most common is type 1. Next point, tests used for von Willebrand disease. The first is it is associated with increased bleeding time. This was what was asked. Bleeding time is increased. Next point, it is associated with reduced plasma von Willebrand factor concentrations. Obviously, reduced plasma von Willebrand factor concentrations. Next, the next test is REPA. REPA stands for Ristocetin induced platelet aggregation test. REPA, Ristocetin induced platelet aggregation test. Ristocetin induced platelet aggregation test. So the tests used for von Willebrand disease: increased bleeding time, reduced plasma von Willebrand factor concentration, and REPA, Ristocetin induced platelet aggregation test. What we mean by this is having a look at platelet aggregation studies. We look at the response of platelet aggregation by exposing them to ADP, collagen, and ristocetin. If the response to ADP is normal, to collagen is normal, but to ristocetin is reduced or absent, then it can either be Bernard-Sollier syndrome or von Willebrand disease. Versus if it is reduced to ADP, reduced to collagen, but normal to ristocetin, then it is Glanzmann's thromboasthenia. This table of platelet aggregation studies is important. Done. This takes care of von Willebrand disease, and we have seen the tests increased. Tests of von Willebrand disease, BT is increased. REPA, ristocetin induced platelet aggregation, the response to ristocetin is reduced or absent. Next.